So without further ado, I'd like to introduce you to our chair for the day, Professor Edward Kunaga. Thank you.
Great, thanks, Ali, and good afternoon, colleagues. Welcome to this webinar where we'll be focusing on health inequalities. My name is Edward Kunaga, as Ali has said. I'm a Director of Population Health Management at NECS, or Northeast Commissioning Support. I also work for an acute trust as a public health consultant, and I do a day a week as an advisor to the Medical Director for a mental health trust. Really delighted to be here this afternoon for what I believe is a very, very important topic. The Connect Health Change webinar series has been running for the last 16 months, and this has provided a platform to share insights across a wide range of topics. Obviously, the COVID pandemic and the COVID implications has been covered in one of the sessions, how we support people to recover from long COVID, pain management, mental health, service redesign, quality improvement. The list is endless. So I would really encourage you, if you have not had the opportunity to engage with these sessions, to go on the website and you can listen in because most of these are recorded. The next session that we have as part of this series of webinars will be running in May, and it is looking at quality assurance in the multidisciplinary team workforces. So again, really encourage you to book yourself onto that one. But without much focusing on what's in the future, the agenda for the day is about health inequalities. I'm delighted to tell you that we've got a very impressive lineup of speakers, people who range from national policy leads all the way through to people who are working on this agenda as we speak. So I will not read their biographies, you've got that in your packs, but I would really encourage you to engage with their presentations because they not only give us examples of good practice, but they also provide us an opportunity for us to think differently about what kind of society we would like to live in. The presenters will speak for 7 minutes. That will be followed by an immediate question from myself. And then we will have a panel question and answer session at the end. I would really encourage you to post your questions as we go along, and we'll come back to those when we get to the question and answer session. So what are health inequalities? Well, there's many different official definitions of health inequalities. But what we know is they all agree that these are socially produced, unfair, systemic, and unjust differences that we see in outcomes across our populations. They can be prevented, they are avoidable, and they are social injustice at its greatest level. They are systemic, which means that no matter where you look, they kind of stare back at you, whatever data you look at in terms of outcomes. So we do have communities, sadly, that don't enjoy the benefits, that don't experience the health outcomes that everyone else experiences. And we know that unequal communities, unequal populations are unhealthy populations. Health inequalities are not just bad for the people experiencing them, but they are bad for all of us. So there is an imperative upon all of us really to understand this agenda and to make sure that we do all we can to reduce the gap that we know exists across our populations. So that's why I'm really delighted and excited on the panel that we have that will look at what are the latest insights, what has been the impact on our populations, how COVID-19 has further shone a light on what has existed for quite some time. But perhaps more importantly, rather than just admiring the problem and talking about it, because that is not what will make it go away, I'm delighted that we've got examples of good practice or emerging good practice that show us what can be done so that we can walk away from this session with some practical things, not just feeling sorry, but also being empowered to go and make a difference. So really looking forward to our presentation, and it gives me great pleasure to introduce our first speaker, Dr. Liz Lingard. Over to you, Liz.
Thanks very much, Edward, and it's a real pleasure to be here to speak about what I'm doing in the regional NHS Improvement and NHS England team. I myself am a physiotherapist by background and spent a lot of years doing academic research around how we got optimal outcomes for our patients. But since I've moved into public health, when you apply the health inequalities lens to that work, unless we transform our services to make sure that they're equitable and accessible for all, and that we make sure we modify the experience for all, we can't hope to sort of level up and improve our services for anyone. So if we just go to the next slide, COVID really did shine a harsh light on the inequalities within our society, and especially from an NHS perspective, people would say we've been a bit late to come to the game here, but we now want to do everything that we can to make sure that the NHS is contributing to addressing healthcare inequalities. So within the NHS, we now have a National Director of Healthcare Inequalities Improvement, Mbola Olabi, who herself is still a working GP as well. And she's listened and worked with a lot of people to set the vision for the national programme. And this is about exceptional healthcare for all through equitable access, excellent experience and optimal outcomes. And in the region, we're working hard to deliver on her 5 healthcare and priorities. And this is around restoring NHS services inclusively, especially with a focus on ethnicity and deprivation, mitigating against digital exclusion, ensuring our data sets are complete and timely in terms of ethnicity recording in all healthcare settings, the Accelerate Prevention programs, and as well the sort of the strengthening leadership and accountability. So if we just go to the next slide, when we're talking about healthcare inequalities, language is important. So when we think about how we address these, it's not the right thing to provide equality. And if you can see here in this diagram, that when people have different opportunities, whether it's their internal factors or it's the wider determinants of health and where they live and work, we need to make sure that we're customizing the tools to make sure that we're addressing these inequalities in opportunities and their own internal risk factors as well. So that's what we call taking an equitable approach. Now, the much bigger public health piece is about fixing the system and actually sort of straightening that tree there so that we have equal access to opportunities as well as the services we provide. Now, we know that's a much bigger picture, and that's what our public health colleagues are working with in local authorities and nationally within government. But that doesn't mean that during these phases, we can't be within the NHS providing equity of our services. So these two things can happen at the same time, and we're very clear that the NHS contribution is around this equity aspect. If we just go to the next slide. It's also important that when thinking about addressing health inequalities, that we do it across the life course, and we have a much greater focus on children and young people, because these health inequalities start from the time of conception and they magnify and widen as we go through our life course. So if we can focus on children and young people, we'll give them the best start in life, and we're also indirectly affecting the health behaviours of their families and communities as well. And it's important that just as we're taking a life course approach, we're taking a care pathway approach as well, so that we're addressing health inequalities in everything we do around prevention, in terms of what we do around health promotion, early intervention, early diagnosis and early management, all the way through to highly specialised care. There's sometimes a disproportionate focus on what we're doing to address health inequalities in an elective care setting or a specialised setting, but actually we need to do this across the whole pathway of care to make sure that everyone in our population has equitable access. If we just go to the next slide, I just wanted to really clearly articulate who's at most risk of facing health inequalities. And often people are drawn to protected characteristics, and although these are very important characteristics, we need to also be more focused on socioeconomic status and geography, so that we know that people who live in more deprived areas are also more likely to live in poorer quality housing, in areas that have higher crime, have, not as nice a sort of built environment around them to access the other opportunities that we have if we're living in the less deprived areas. We know that they're more likely to live in overcrowded housing, and we also know that this is where populations of people are who experience homelessness or rooflessness are as well. And what's often in these communities is, access to lower incomes, so ability to work or unemployment are much higher in these areas as well. And we know that they'll have lower educational attainment on average, with having very high levels of poor literacy and health literacy. And then there's a much wider, more detailed list of others who face health inequalities, including sort of inclusion health groups, but thinking about people who have serious mental illness, learning disabilities and autism, people who have sensory impairments such as hearing and vision loss as well. And what's most important is to remember that these things don't happen in isolation. So where they intersect and come together, those people face much greater health inequalities than people who haven't any of these risk factors. We just go on to the next slide. So I just wanted to really sort of focus in on the health literacy and digital literacy challenges, because I think these are recognised by us out in the healthcare system when we're thinking about delivering interventions. So it's quite chilling to think that nationally 61% of our population find health information too complex for them to understand. And when we're talking about health literacy, we're referring not only to written text, but also numeracy as well. And I've put in a web link there that'll drill you down right down to your local authority so that you can see what proportion of your population will be struggling with this information, to help you think about the impact that might have not only on access to your services, but the experience people have and actually the outcomes they have in understanding materials that are given to them during their consultations and onward to manage their conditions. Digital literacy is also a massive challenge, and with the drive to the digital by default really is a worry for us, because we know it's exclusive by design. So anywhere that you're putting in digital interventions, you need to really be aware of the inequalities that this might drive up and what you're putting in place to mitigate against that. We just go to the next slide, thanks. So really regionally, we're getting people to think about this as a bit of a checklist, that you understand all your groups who are accessing services most at risk of health inequalities. So even if they're not coming through your door, you need to be cited on your population and those who you think may be really struggling to access services in the right place, and where they may be just pitching up to A&E because they're really struggling to understand how to navigate the system. They may have limited English proficiency, which makes it very difficult for them to do online tools or call 111, etc. as well. That we're taking a population health management approach to view the data so that we're segmenting the data by deprivation, ethnicity and other inclusion health groups, so we can really focus in on what are the areas we need to improve and monitor going forward. And where we know we want to focus, we co-produce these healthcare services so that we're putting in evidence-based interventions, but we're making sure that they're delivered in an acceptable, accessible and affordable way for the populations that we wish to serve. And this isn't just about sort of the health literacy and digital inclusion as well. It's looking to make sure that these are culturally competent services as well. And I really like the learning disability sort of narrative around making reasonable adjustments to our services so that we can make sure that this cuts across everybody with a healthcare inequality. We also need to make sure that when we're providing services, as I mentioned earlier, it's not about equal provision, it's about equitable provision. So we have to have this proportionate universal approach, and there will be some instances where you have to have weighted funding for services for certain populations as well. And we need to take not only the public with us, we need to take our internal workforce with us as well. So we need to invest in comms programs that are outward facing as well as inward facing to make sure that everybody signs up and goes forward with this journey. And we need to link in with the experts in our region as well. So we know sort of in the northeastern Yorkshire, and it's no different in any other region, we've got lots of public health teams in local authorities, in OHID, which is the Office of Health Improvement and Disparities, previously Public Health England. We know there's lots of work happening in our clinical networks with our voluntary sector groups and patient groups. And we know that there's been a lot done during COVID to build these trusted relationships between these groups. in the voluntary sector and local authorities. So we really need to harness what's happened there to make sure that that's how we're building services to go forward, so that we really make sure that we understand the issues and we're delivering services that are fit for purpose. So now more than ever, I really sort of call on you to listen, learn and work together to make sure that we improve and level up our services to improve outcomes for all. Thanks, Edward.
Great, thanks Liz for taking us through what is a very comprehensive presentation and also leaving us with some practical things of what we can do. Just a quick question from me, how do we balance the effect that we've got a massive backlog, certainly with the elective recovery program, and how we get on top of that as fast as possible, whilst at the same time making sure we do not widen inequalities? What are your thoughts on that?
Yeah, thanks, Edward. That's a really good question, and I have to admit is a real tension out in the systems at the moment, but that's the key to it. We now have integrated care systems and we need to work together to find the solutions for this. And I'd say the way that we balance is it's to have really strong leadership and awareness of what these issues are. It's morally and ethically the right thing to do, but even if you don't have your heart in this, it's financially the best thing to do. So for the individuals, for the community, and for the taxpayers, this is the right thing to do. So if we can change the mindsets of how we do this and really focus on this, we will be moving towards better ways of working, and it will actually take the pressure off the healthcare system if we trust this as the direction of travel. Thank you.
Thanks, Liz. I quite like how you have kind of turned this to not just being a moral issue, how there is a financial and an economic imperative, and that's why health inequalities are bad for all of us, and not just the people who are on the receiving end. Thanks for that, Liz. We'll come back later on in the question and answer session. It now gives me pleasure to introduce our next speaker, Professor George Peat. Over to you, Professor Peat.
Lovely, thank you, and thanks for the invitation to present on the subject of primary care data. Next slide, please. So I hope that most of you will already be persuaded of the importance of primary care to musculoskeletal health. It relates to the volume of care that's provided in this setting, its key functions that I've listed here, and the orientation to health across the life course for a defined population, not just people presenting with a problem. And primary care data arising from that activity is one of the jewels in the crown of health data in the UK, but it's not without its challenges, particularly when applied to some of the common non-inflammatory musculoskeletal conditions. The data, of course, exist not for research, but to support clinical care. Nevertheless, if they're handled with care, they can give a unique and powerful source of evidence on health inequalities that can inform action. Next slide, please. Here's a first illustration. In this, we're using national primary care data from CPRD Orum to describe the rate of presenting to primary care with low back pain and osteoarthritis. We can see that there's consistently higher rates of consultation among adults living in the most deprived neighbourhoods in England compared to the least deprived. In fact, it's about 30 to 50% higher workload in those areas. And what's more, we can see that the gap has changed little over the last 15 years up to 2019, in other words, pre-COVID. As expected, there's a north-south divide, but actually it's inequalities by deprivation within each region, which are pretty substantial. So really the problem isn't a regional one so much as on inequalities within region as a particular problem. Next slide, please. What's the setup of care in these deprived areas? Well, previous studies, particularly by groups in York and Manchester, that have linked morbidity data from the primary care electronic health record with GP workforce data and funding allocations, suggest that relative to need, practices in these areas tend to be underfunded, underdoctored, that accessibility and satisfaction is often lower and may even be declining. To my knowledge, this kind of analysis hasn't yet been done at the national level specifically, for the provision of musculoskeletal care in primary care, but it's obviously important to look at developments around first contact practitioners and other sources of primary care for MSK. A last point about the relationship between primary care supply and outcomes. First is that greater investment in primary healthcare does tend to produce pro-poor outcomes. In other words, it reduces inequalities, although clearly it depends on the nature and extent of that investment. But that also simply investing and expanding the primary care workforce and paying for quality may not be sufficient to lead to any big reductions in health inequalities. Next slide, please. Now, beyond inequalities in musculoskeletal contacts and workload, what about inequalities in care that MSK patients receive? Well, again, we can use primary care data here to look at relative rates of care that we might designate as high value or low value. Here's an example: gabapentinoid prescriptions in consultants with osteoarthritis, which increased enormously over the last 20 years, despite evidence of no particular effectiveness or cost effectiveness for this condition. And especially those increases were in areas of more deprivation. Similar inequalities in long-term opioid prescribing have been reported in many other different studies. So here again, primary care data, this time of prescribing attributed to musculoskeletal conditions, together with information on social characteristics, can be used to indicate variation and at least act as a starting point to investigate unwarranted or inequitable care. Next slide, please. But we need to stop here and just acknowledge some of the major gaps in the data that should be evident in what I've already shown you so far. First are data around other measures of socioeconomic position and social risks, including historically on ethnicity, which I know Liz referred to there. Also, I've talked about prescription data, but actually the provision and uptake of recommended non-pharmacological interventions is important, but again is systematically under-recorded and difficult to obtain through existing data. And lastly, where's the patient voice in all of this? Do we have enough information on patient-reported outcomes and many of the important covariates, such as psychological and social factors, that influence outcomes? These gaps have to be filled or bridged through linkage or through new data collection. Next slide. Here's one local example here from research that we've been doing funded by the Nuffield Foundation versus Arthritis, linking patient-reported information against primary care electronic health record. What it shows are modelled estimates down to the level of neighbourhoods, that's 1,500 residents for each area there, the prevalence of high impact chronic pain. And this is across North Staffordshire and Stoke-on-Trent, although I suspect you would find very similar patterns in other areas. Deprivation's the major driver of this pattern, but the data hopefully are a lift-off point for the obvious question, which is, are local services sufficiently tailoring to reflect that sort of variation in need? Next slide, please. A second illustration, perhaps a little bit more techie, but this time looking for ways of less resource-intensive collection of data. Here we're using data from the electronic health record in primary care to predict who does and doesn't have high-impact chronic pain. We don't need to do that with a high degree of precision if we're not using it at the individual level, because instead what we're doing is applying those prediction models to national and subnational electronic health record data to produce those prevalence estimates that I just showed you on the map. So again, no need to keep on going out on a regular basis with very time-intensive surveys. Next slide, please. None of this addresses what I think is one last critical question, which is, do musculoskeletal interventions that we're currently providing unwittingly widen inequalities? And Liz talked about some of the digital interventions where that indeed is a major concern. But for many of the non-pharmacological interventions we're interested in, to answer this sort of thing, we have to step entirely outside of data that's currently available routinely in primary care. The ideal answer to this comes from robust subgroup analyses of trial data, but such data we know are rarely available, as we indeed found in this review of several published recommended interventions that have good trial evidence of their clinical and cost effectiveness. But we don't know whether or not they are importantly different in their effect for different groups of patients. However, instead of waiting for more trial data that may never materialise, given that there's already widespread rollout of these, a better bet will be to build into the implementation phase of these interventions the routine collection of more social variables to understand these differences in outcome. That's the approach that's used, for example, in the GLAD osteoarthritis programme across in Denmark. Every patient and every physiotherapist that joins those programmes contribute data to the national registry, and using those we can start to look at some of the inequalities in outcome. The evidence that we get, incidentally, from the analyses of these are that inequalities in outcomes are relatively modest. By far and away the bigger priority is improving access and accessibility of these interventions to underserved groups and individuals. Next slide. I'll just finish there with a couple of acknowledgements to funders of some of the research that I've presented, and thanks for your attention and any questions.
Thank you very much, Professor Pete, for your very enlightening presentation. And I think you have exposed what some of us have felt for a long time, which is the agenda around health inequalities for a long time has focused on the biggest causes of mortality. So the things that end up, so your cancers, your cardiovascular disease, respiratory illnesses, but perhaps has not done the same justice to the things that cause pain, suffering, and misery. And musculoskeletal conditions, we all know from the global burden of disease that they are one of the leading causes of poor health. So again, seeing the inequalities there staring back at us perhaps puts a stronger impetus on us doing something not only about length of life, but also about quality of life. And thank you very much for that. Just a quick question from me regarding primary care data and some of the challenges you have outlined. Is there something that we can do specifically that you think would help us unleash the potential of primary care data? And I know James is kind of waiting on the wings to start talking about some of the benefits of primary care data, but I don't know from your perspective, anything else that we could do to unleash the massive potential primary care data has?
Well, I think, as you say, we're going to hear from a couple of specific examples later where people have gone on to use these data to inform action. I suppose my reflection is, having witnessed the extraordinary response to COVID, and that included a response around data and its access and integration and use to inform policy and practice. I suppose my one hope would be that that won't get lost, and that will now get transferred and built on for the sorts of non-communicable diseases such as musculoskeletal health and care that we're talking about. So I think that's my big hope at the national level. I suppose there'll be a lot of hope around the ICBs and how they will use integrated data within their localities. And I suppose here that my sense is that on its own, primary care data has some use, but it is of far greater value when it's linked. And so the mechanics and the ability to link it are critical here.
Thank you very much, Professor Pete, for the response to that and for your presentation. And I'm sure we'll come back to those issues in the panel discussions. So our next presenter is Dr. James Prentice. James, over to you to bring to light what Professor Pete has been talking about.
So thanks very much, Edward. My name's James. I'm one of the consultant anaesthetists at the Freeman Hospital. Next slide, please. So I spent 6 months on a COVID ward, and during that, COVID respiratory ward during the first and second wave. And what was easily noticeable was the decrease in elective care that we were giving for patients. We have got a massive backlog, and it's putting us all under a lot of strain to try and impact in some ways on this. And of course, day surgery cases, though it was equally split. The sheer number of patients, the sheer number of day case operations we did over the pandemic fell dramatically. Next slide, please. So just a few declarations before I start. I'm a bit of a lefty and I've never set foot in a private hospital. I'm a card-carrying member of the Labour Party and my dad was the General Secretary of Unison. So take what I say with a pinch of salt if you want to. Next slide, please. So my big interest, and going back now 10, 15 years, has been around prehabilitation. My feeling at the moment is with these interventions before operations, that we've got a potential to actually create a health inequality that wasn't there before. Now, I quickly put in to get a picture of prehabilitation, and this was the one that came up, one of the first ones. They're not the patients I see, and they're not the patients who need it. To put a little bit more context around this, I was speaking to one of the prehabilitation leads of a hospital down south who was undertaking a surgery school, but they were getting everybody in to talk around the risk factors and how they can improve their health and get better before their planned major cancer operation. She turned around to me and said they were taking smoking cessation out as only 2 patients had attended with smokers. And in the next breath told me that they can't get anyone from socially deprived areas to attend. So in my view, we've got a big risk of getting fit patients fitter. And also comparing those patients that engage with a prehab intervention versus those that don't engage isn't the way forward in my eyes. Next slide, please. Now, I've always had a massive problem. How do we find the patients? Patients come to the outpatient clinic, the orthopedic or whoever consultants now see them and refer them on to pre-assessment. They don't take the full medical history quite as much as they used to do because it's been negated to us down in our pre-assessment clinic. So getting the patients in has always been an issue. Patients, we know that the waiting list is longer than it's ever has been. Primary care is stretched. And there's also multiple ways that we can get onto a hospital waiting list for an operation. From the GP, from referring in from other hospitals, from TIM services, physiotherapy services. And the other thing about all of this was pre-assessment is also under a massive amount of pressure. All those patients that need to be seen before their operation or haven't been seen for 2 years need to be seen again. So patients are either seen months ago and we're having problems on the day, we're having to pre-assess them, or they're being seen 1 or 2 days even before their hospital admission, not giving us any time to really make an impact. Next slide, please. So with a bit of a throwaway conversation with my COO at the Trust, he said, oh, we've now got a database of everybody who's waiting elective care within Newcastle. And speaking then with Edward and his team via a colleague, a public health colleague at the Trust, we were actually able to merge our waiting list for the entire North East and North Cumbria onto GP data. So just from this, you can see that there's about 40,000 patients awaiting elective surgery. What we classify as P3, they can wait over a month, or P4, they can wait over 3 months for surgery within the region. Of those, the vast majority are living in socially deprived areas. You're looking at about 40 to 45% of our patient population. Next slide, please. And what does that mean? Well, we can pull certain things very easily from the dashboards. If we look at uncontrolled diabetes, for example, we've got nearly 2,000 unique primary care records of patients who are now we're just sorting out some information governance issues, but we can now target, and we've got the time to target. We've also got about 5,500, 6,000 patients who are smoking. Again, the vast majority of these are from socially deprived communities, which is a worry when it comes to how do we engage, what do we do, and how do we do it. So the next few slides are just going to be around that. Next slide, please. So we've engaged with all of these partners within Newcastle, including O2, to really target digital inequalities that are evident within our population. Next slide, please. And just a few things that we're doing. We have got a randomised control trial currently recruiting, looking at a walk-in intervention versus a soft digital COVID-proof multimodal behaviour change intervention run by a third sector organisation, targeting smoking, alcohol, exercise, and all the things you can read there. We're giving out tablets, Fitbits, MiFi devices for all that know it, and we're about a third of the way through recruitment now, and it's going actually really well. Next slide, please. We've also got bigger plans. We're just about to commence all of these interventions are based around that voluntary care sector model. We've got similar interventions planned for aortic aneurysms, and pancreatic cancer randomised control trial has just been funded. We're using the dashboard to pick up patients with diabetes, and they're again going into a voluntary sector organisation to undertake the diabetes intervention. We should be getting the results actually the next few weeks. Engagement's great. The dashboard was brilliant for picking patients up. We've got our first 2 patients through, and they've both dropped their HbA1c by about 18. We're now funded, which is the first time ever, and we're looking at rolling this diabetes pilot out across the whole of the North East and North Cumbria. We're thinking about how we support patients on strong opiates, and hopefully they're going to develop a central hub whereby they can target social deprivation, ethnicity, along with the comorbidities that may go along with that, including smoking and exercise. So in my view, it's been brilliant just to get things going and see this happening. And it's probably the best thing I've ever done in my career, to be honest. Thank you very much.
Great, thanks, James, for your presentation and building up on Professor Pete's presentation on the value of primary care. This is data that sits there that with a little bit of data linkages, you'll be able to gain more insights and provide more targeted support for the patients. And your point around widening inequalities, we know that those with pointy elbows always push their way to the front of the queue and end up benefiting from any intervention you put in place, and how these needs to be carefully designed. Otherwise, they widen inequalities and lead to more harm than the benefits. Just a quick question from me, James. The first one is to do with kind of the waiting list and the elective recovery program. So are you suggesting we need to do the elective recovery program differently? And also, what does this mean for perioperative medicine?
No, I don't. I don't think we need to do things differently. I know that there's a massive backlog and we need to get going as much as we can do in the hospitals, and essentially we're trying our best. What this means is that whilst those patients are waiting, that we can actually intervene and do something that's going to improve their perioperative journey. Now, if we can improve someone's diabetes, that's not, or get them off insulin, that's not only good for us, it's good for the long-term health of the patient, it's good for primary care. And what we're doing is using surgery as the sort of golden moment of behaviour change. And from the work, the initial work that we're doing, it does seem to be the case that people are far more likely to engage. They're more likely to engage with secondary care, with one of our consultants or one of our team ringing them up saying, you've got to get involved in this. It's a bit of a carrot and a stick, to be quite honest, but it seems to be working, which is great.
That's great. Thanks, James. And we know that being listed for surgery or waiting for surgery provides people opportunities to reflect. And as you've pointed out, there are immediate benefits for surgical outcomes and hopefully longer term benefits in terms of their ultimate health, which is good for them and it's good for the system as well. So thanks for that. We'll come back to some of that in the discussion. Thanks. So our next speaker is Kerry Page, who's going to talk to us about how this agenda needs to not just be about nice, shiny hospitals, but also working with those who are closest to the communities. Over to you, Kerry.
Hi everybody, I'm Kerry Page. My background is I'm a public health nutritionist, but I'm also passionate about co-designing and developing programs that do work with people to hear their views in the community. So if we go on to the next slide, please. I work in a voluntary care sector charity around health and wellbeing, and we're working very hard to connect with clinical settings and work more collaboratively. And as part of that, we were commissioned along with Modality, which is a GP super partnership, to try out a 6-month pilot to co-design and test a care pathway for people with MSK conditions and pain. And we're talking about a cohort here with high impact chronic pain who would be expected to face health inequalities at a fairly high level, I suppose is the way to put it. The key part of what we were doing, I'm not going to read all this to you, was that we looked at a pathway where people could move back and forth along the pathway between clinical and community healthcare, and that the co-design was used to really hear the voices and direct what happened in this pilot across the period. So that was essential part of what we did on a day-to-day basis, which is very rare. I would caution that anybody who ever funds anything like this again, co-design does not happen. This was initially meant to be a 3-month pilot. We extended it to 6 with our own funding from the charity. So don't commission anything for 3 months if you want to co-design and really find out what's going on with people with health inequalities, would be my take-home message there. So next slide, please. Well, they really gave us a challenge, I'm going to be honest, because they said we had these patients who were medicated, non-cure seeking, and from all kinds of backgrounds. So I've listed our cohort of 44 patients and some of the expectations of them living with health inequalities that we had. Our group were Eastern European, BAME backgrounds, people with learning disabilities, and people who lived in very, very deprived areas in Keighley and Bradford. And how we were going to help them, or try to help them, was by connecting their medical care and their GP care with some of those things you'll see on the left. And when you're thinking about people who are really isolated, mostly at home, not connecting with their community networks and so forth, getting them to talk to us about getting physically active, their diet, their social networks, pain management that wasn't medication, mental health and crisis management, you'd think was going to be a really difficult thing to achieve. The astounding thing was that from that MSK pain service referral or GP referral, not one of those 44 people put the phone down on us. Anyone who lives with pain will grab hold of help. So that was a great start. But what was really interesting was that they maybe have been totally new to the concept of community healthcare and the support that could give them. So there was something to explain there, but that clinical referral from a GP who mentioned this programme of work was really crucial in building their trust to engage with us. So if we can go on to the next slide, please. As I said, co-design existed in all aspects of this pilot. That was essential for the patients and very much something that I drove with the rest of our team. I just want to say that in terms of co-design, there were no tools there for us. We were making this up as we went along. So, you know, we didn't come out after 6 months with perfect tools, but we designed tools to work with these patients. So I talked about the referral process, but we started right at the beginning. How do you want to receive information? What is the right kind of language to you? What will you engage with? And they told us really simple stuff that we know. Don't give me loads of literature. I can't read. Don't call me early in the morning. Don't tell me to look at a website. And I think that mirrors some of the things we've heard here, because people who have high impact pain are not like touch contact. This is not going to work for them. So I suppose when we're talking about tackling health inequalities, we've got to think about these people really differently, and we've got to give them time, energy, resource, and it's got to be funded. So I'll repeat that right at the end. But we talk to them about how to engage them, how they'd like to enter a building, what they'd like their room to look like, you know, what steps that we need to engage them. And those wellbeing calls and building a relationship were absolutely crucial. In the end, again, staggeringly, out of 44 patients, 40 ended up in buildings in community centres across Keighley. The other thing we talk to them about, we tell them about a community health offer, you know, that around those topics I spoke to you. And sometimes people go, oh, I might try that. That sounds okay. So some people took a few calls and then we got contact. Others took 6 months. But what we also asked them was, well, what would you like to do? What do you think will help you? That was amazing learning, what they told us would help them. So as well as the structured offer we had in communities, it was what do we need to add? What do the VCS need gaps that needed to be filled, and how will those be funded going forward? And that met the need of people with pain and MSK. And then things like pilot peer support groups. What topics do you want to hear? What are you interested in? And they told us, they said, tell us how to sleep. Tell me what food I can eat to give me energy. Tell me about diet and inflammation. Tell me about diet and immunity. Tell me what I can do in terms of helping myself. Next slide, please. Right, really quickly, I'm running out of time. I'm going to tell you about Richard really quickly. This picture makes me so proud. This was a man who walked into our centre, bent double, dishevelled, massive sense of anxiety, not working, just had, as the quote said, just really wanted to give up, completely give up. The engagement tours took a lot of time with Richard, but in the end, this gentleman attends, would you believe, 7 exercise classes. He has, through building confidence with him, through social contact and peer support, now attends exercise groups that are meant for him. He's never going to go to a leisure centre, he's never going to go to a gym. But what we did was we hooked him up with things that would suit him. He lost 2 stone in weight. He now does not reach for his medication the moment he opens his eyes. He's becoming an expert by experience. He has a purpose and a role. And this picture makes me proud because you can see in his eyes, if you'd seen him before, that he is a completely changed man by being supported in his community. To finish up, next slide, please. I've put some things on there that you can have a look at later. Obviously, I don't have time to go through them all right now. But again, I just want to reiterate to all of you, for tackling health inequalities with some of the cohort we spoke to, light touch engagement is not going to work. We have to have really effective, what I would call active signposting. Social prescribers are doing a great job in that respect, but you've got to have people who really know and understand people in their communities prescribing as well. Online support not effective, and that you've got to invest time, money and resource, and you will help these people. They will not turn you away. One other thing to mention is a lot of these took crisis management as well as part of their being able to then talk to them about their health, welfare benefits, housing. So we linked them up with a crisis management support team, and for some people we had to get over that barrier to take them forward. So I'm going to leave it there. The good news is there's been incredible interest in the pilot, and we're hoping that we will extend it and maybe get to test some of this out across Bradford next year. Thank you.
That's great. Thanks, Kerry. Very exciting work that you are doing there. Just a quick question from me. I mean, voluntary and community sector doing pain management, that's not the norm. How well has this been received by GPs and by patients? So
I would say in terms of patients, as I said earlier, the idea of community health linking with their medical health, and that the 2 things could support each other and that they could, you know, be helped not necessarily to become off medication, but to reduce medication or manage better day to day, was kind of a new concept to people. It was rare that they understood, because people are so medicalised and they're looking for that medical answer. So, you know, there was some work to do with people there to say, well, actually, to manage day to day, this might help or that might help. So that was one aspect of it. The other thing was, I think some of the GPs who worked with the voluntary care sector were really surprised at how professional we were and about what we could offer. And there was a process even within their surgeries or their teams to build confidence to work with us and get used to us. And what I would say is, I'm going to give you some feedback from a GP, is he said that the contact with community health offer helped demedicalise pain for some of the patients, in line with NICE guidelines. He said that it offered a great opportunity for their 10-minute or short appointments to extend care, and that it was more sustained care that they were receiving and day-to-day care in their communities. They had patients within the cohort who, for example, used to ring 86 times in a week because one woman was so anxious about her condition. She met a few friends and started going to a social and art group, and she stopped phoning. So the clinical indicators for this, I've got to tell you again, because of the short duration of the pilot, they didn't mean much. We needed a much longer period of time, so any future work will have that. And that the VCS are embedded in the community. We're already there. There's this massive piece of support for medical practitioners to dip into if they know about us. So he said he was talking to his teams a lot more about that.
That's great. Thanks, Kerry. We'll come back to some of that later on. Our next presentation is Linda Hindle. We've heard about local, we've had some regional, and Linda will give us a national perspective. Over to you, Linda.
Thank you very much. Yes, so I'm the Deputy Chief Allied Health Professions Officer, and I work in OHID, which Liz mentioned at the beginning is the new home for part of Public Health England. So yeah, I've been asked to talk about what frontline clinicians and managers can do to help address health inequalities, and that's partly because of a piece of work that I led with allied health professionals. So whilst I'm going to talk about that piece of work, I want to point out that it's applicable across all clinical groups. So if you could move on to the next slide, please. So part of the reason that we started to do this piece of work was because I was getting a sense from the clinicians that I was talking to was that they've got a real interest in wanting to do something about health inequalities, but didn't really know where to start because it seems such an enormous issue that requires input at every level. And so as an individual healthcare professional, sometimes it's difficult to see what our individual contribution can make to that big picture. So it's like the analogy of kind of eating an elephant. How do you do that? One step at a time and one individual at a time. So that was the essence for doing the piece of work. So if we move on to the next slide, please. So this is the framework that we developed collaboratively between NHS England, what was Public Health England at the time, and the King's Fund. So it involved talking to a lot of clinicians individually, through focus groups and through surveys to understand what we were doing already, what the barriers and opportunities were. And the resulting framework encourages us as healthcare professionals to look at this issue of health inequalities through 6 different lenses, really 6 aspects. So us as individuals, ourselves, our own values and beliefs, the work that we do with individual patients, the work we do as part of clinical teams and pathways, our work in networks and communities, the role that we play within the systems that we work in, and also the role that we play nurturing the future workforce. And within each of those aspects, we looked at what do we need to know, or what don't we know already, what should we know, what actions could we take, and what further advocacy role could we play. So just to talk very briefly about some of those areas in relation to self, because we often start off with patients, don't we? But looking at ourselves first, which is what the King's Fund often encourage us to do in this kind of space around health inequalities. It's about considering our own stories, our values, our worldview, our biases, and learning more from our colleagues and the people that we work with about their stories, so that we can get a broader understanding of the kind of different contexts within which people live and the barriers that they may face in terms of accessing our services. In terms of care of patients, you know, Liz talked about being able to consider how we care for everyone equally well, which of course is what we all want to be able to do. So that requires us to think about what extra or different care do we need to give to those who are at a greater risk of health inequalities, which might include signposting to other services, as Kerry's just been talking about, and ensuring that we're not putting additional barriers in place like technology or language. In terms of the clinical pathways and teams that we're in, it's about considering who we're reaching and who we're not reaching. So again, kind of it speaks to some of the presentations that we've already heard, and looking at kind of what are the opportunities to reach those groups of people who are underrepresented in our services. From communities and network perspective, really kind of following on from Kerry's presentation, that focus on understanding the populations that we're working with, co-production, co-design, asset-based approaches, and using the insights that we might learn from those types of conversations to be able to develop our services differently. And then from a systems perspective, a lot of that is about paying attention to those kind of cross-boundary issues and taking steps to ensure that the flows across systems and across teams work really well, and that we don't disadvantage people. But also thinking about the diversity of the workforce that we employ and making sure that we're as representative as possible of the populations that we're serving. And then the final area about nurturing the future, again, is about making sure that we've got a representative profession, and that we're consider making our clinical roles as accessible and attractive to a wide range of people, particularly diverse and underrepresented communities. So that is very much a whistle-stop tour of that particular resource. But if we move on to the next slide, I wanted to just share with you a piece of work that we did with Cambridge University to look at the impact of AHPs on public health, and not really to share the work as such, but to share the way that the research team unpacked health inequalities, because I think it's a helpful way for helping us as individual clinicians to think about the different parts of the system in which we can interact. So what they did was, as we've talked about in early parts of this presentation, looked at healthcare inequalities and health outcome inequalities separately. So the outcomes is the increased risk of morbidity and mortality that people might experience, and that's maybe where it feels difficult for us to intervene as individual clinicians. But the healthcare inequalities are around not only the patient but also the system, and how we have inequity in access to services, diagnosis, treatment and experience, but also the funding and where we place the workforce. So again, I think sometimes breaking it down in that way can help us to think about where is our specific contribution. And I want to finish off just by sharing 3 tools that as clinicians I think can be really useful for us in thinking about how we kind of shape our practice. So moving on to the next slide. The first one is a tool, and I've put the links to all of these, about embedding public health into clinical services, which obviously links to health inequalities as well as the prevention, early intervention agenda that we've been talking about. So this resource was developed bearing in mind how busy clinicians are who want to make changes but don't necessarily know where to start. So it helps you to kind of go through a systematic process of thinking through what is your unique contribution to improving the health of the local population, and how do you create the vision and the narrative to change, and then use quality improvement methodologies to make that change, being as big or small depending on the amount of time and capacity that you have within your team. The next slide is the All Our Health framework, which, if you've not seen it, is available on the .gov.uk website, but also e-learning for health modules. And this provides detail about 24, I think, different public health issues, from obesity, physical activity, through to homelessness, exploitation, to very quickly show you what is the evidence base, the outcomes frameworks that are relevant in this space, and then finally what actions you can take as a clinician. And finally, last slide, and no amount of time, is the AHP social prescribing framework, which again links very much to what Kerry was talking to us about. So that's me, thank you.
Well, that's great, Linda, and thanks for your presentation, because oftentimes we kind of think, oh, well, this is a bad situation, and we kind of left helpless. And I think what you have done is to bring it to life, which is how we can all do our bit in the places where we work and the interactions we have. So thanks for that. And I'll probably start off the question and answer session by asking you a question, and then I'll bring other colleagues as well. So what has been the response from allied health professionals?
Thanks. Do you know what? It's been incredible, because you know, I kind of thought when we developed this that it was maybe a bit of a niche area, but the amount of teams that have taken this on board to have discussions within their team meetings, to look at how they can redesign their service, to incorporate it into their strategies, it feels as though breaking it down into kind of individual components has helped people to who had an interest but didn't really know where to start to really get on board and start working on this agenda, which is wonderful.
That's great. Thanks for that. I'm just looking at the questions that have come through. A lot have been endorsements and thank yous from people, but I've just got a question here for you, Professor Pete, which is, what are the key lessons you have learned from the data in changing how services are designed?
So I suppose my first one is that I guess unless you get to fairly granular levels, you probably underestimate just how focused and targeted you might need to be with service targeting, because I think at the current level, I think we tend to talk about things like CCGs or ICSs or local authority level data, but actually within those, and anybody who works within those know that there are subpopulations where the need is vastly different. What I think is not necessarily connected is that services and resource and workforce and supply follow that need. It feels that doesn't happen very often, and you know it's a bit of a trite thing to draw attention to things like the inverse care law, but I think that's still there and it's still very evident despite a lot of the efforts recently. Now, whether or not expansion of workforce, and I think that's the other thing that we've tried to do, is where there's opportunities where the workforce expand or introduced, for example, around FCPs for musculoskeletal care and primary care, is there an opportunity to do things differently that is more equity informed? So I would say that's probably it, but you're speaking to an epidemiologist who often relies on my collaborations and colleagues at the action end of things very often.
No, that's great, and probably just leads us neatly into a question for you, Liz, which is how do we avoid just building back better to more building back fairer, and how do we straighten more trees? I've got visions of you going around straightening trees, Liz.
I'm doing that standing on the shoulders of my public health colleagues out in the local authorities and OHID and working together and being a strong advocate and a champion for them. So I do think we have a role as anchor institutions as well to make this the culture of our organisations and everything we do in terms of sort of recruiting the workforce and making sure we've got a workforce that's fit for purpose as well. So if we are going to build back fairer, we've got to also recognise that 1 in 10 people in our population work in the NHS, and in the Northeast it's actually 1 in 8. So actually our workforce are facing health inequalities as well. So if we're building back fairer, we're doing an inside out sort of workforce as well as the population as we move forward. But we can't do it unless we've got strong leadership. I just keep harking back to we need strong leaders, and I'm not saying people who are chief execs. Everybody who is listening on this call I consider to be a leader. So I would, really have a call to arms for everybody who's listening on the call to take this as part of their responsibility going forward, that you're sort of arming yourself with the information and training and skills that you need to be a champion for this to go forward. So if we've got strong leadership, we can change the culture to build back fairer.
That's great. Thanks, Liz. James, question for you here. Are you an exception in terms of the practice and the interest in inequalities as an anaesthetist, or is there a movement in your profession?
So it's difficult. I'm not going to say it isn't. There's some of my colleagues who probably don't agree that we can make any difference. But anaesthetics is changing, and anaesthetics is changing into perioperative medicine, and it's a brand new speciality, and we've got the opportunity to make a difference and have this as one of the key agendas moving forward. As I mentioned before, with surgery, we've got the opportunity of that sort of golden moment for behaviour change that will not only impact on perioperative outcomes, but also long-term health, readmission rates, GPs under pressure. The amount of letters I see going out from our department back to primary care is crazy, and we can do something about it. So I'm not alone. There's lots of other people involved. We've got people in every trust in the Northeast who is going to be taking on the Waiting Well project. And it's exciting times. It's new. So it's not everyone, but we're getting there.
That's great. Thanks for that, James. And Kerry, I'll come to you next in terms of the role of the voluntary and community sector. I mean, if there will be people on this call who are listening and going, oh, that's quite great, but I don't live in the same area as you. What would your advice be in terms of getting more aligned and more co-production with the voluntary and community sector?
I'm out of practice, guys. Sorry, we work person to person so much now. I think absolutely. I think one of the reasons these two small pilots across North Yorkshire and Bradford have generated so much interest is that we're fairly unique in trying to take some of the theory and knowledge and all this data you guys have and go, well, that's brilliant, but what does it all mean for real people who face inequalities in their day-to-day lives? I feel quite overwhelmed by this task on some days, I'm going to tell you, and working with people with chronic pain has been such an eye-opener to me. I feel very passionately about it, which is why I've gone and spoken to people across the countries about the incredible results of this pilot. And all I can do from my perspective and the VCS perspective is trying to head turn clinical settings and medical professionals to that benefit of linking with the VCS and community health offers, try and just turn heads at this point. And then what we've also done is we're going to try now to take some of the because essentially the pathway, what works for people to tackle health inequalities, it's not rocket science, it's really, really commonsensical basic actions that can be taken if we invest time in people. Engaging people who face health inequalities takes longer, we've got to accept that. But what we're doing from our perspective now is we're going to see what parts of that pathway are transferable to other areas and scalable. So that's part of the next step in terms of trying this out across Bradford in some different communities. And then to, again, try and raise awareness of the outcomes of that. And again, what's scalable and transferable. It's not going to happen overnight, but at least we can get people thinking about a different way of working. And I really think the voluntary care sector and the community health offer is phenomenal what we can do. So I think GPs, PCNs, ICS have to start thinking about the community sector as not being, you know, somebody called us the third sector the other day. It's not the third sector, it's the voluntary care sector, how we work more collaboratively and what are the benefits for both. The other thing that needs to happen is, and I'm thinking about this for the next piece of work I do, is, you know, there's real gaps in the research here, academic research, so there needs to be more robust academic evaluation about some of these outcomes, and the clinical settings need to jump on board with, you know, if we look at less admissions at A&E, less appointments, shorter waiting lists, let's get some of that data that's of a better quality than we were able to in 6 months, so we can really shine a light on what this can achieve.
That's great. Thanks for that, Kerry. And I'm afraid there's a few more questions, but we've run out of time because I want to give the panel just one take-home message, and you've got less than 20 seconds to do that. So I'll take you in the order which you presented. Liz, what's your take-home message?
Collaboration, Edward. I think you've heard from a range of speakers today. Seek these people out that are in your area, whether they're the experts, the patient groups, the trusted groups, the people who are delivering great interventions like Kerry explained as well. They're all within your own patch. Seek them out and collaborate.
Great, thanks, Liz. Professor Pete, what's your take-home message? 20 seconds.
Use data to inform your actions, but be critical of the data and keep pressing for more equitable data.
That's great, thanks. You can come back again because I'm working in data, so I like that. James?
Just do something. That's it.
Great, thanks, James. Just do something. Kerry? Oh, Kerry, we can't hear you.
I think what I said before is, let's really, if we want to really engage people with MSK and pain and tackle health inequalities, let's really open our ears and listen to what they say will help them alongside their medical care. Great,
and last but not least, Linda.
Thank you, and I think similar to James, we've all got a role to play, so however small it is, just see what you can do to make a difference.
That's great, and thank you all for joining us. There's a feedback survey. Please take 2 minutes of your time to help us for future events, and we look forward to seeing you again. Ali, did you want to come back in?
Thank you so much. Yes, it's been an amazing session and lots of rich content. Just a quick mention of our next 2 webinars. They are on the 4th of May, Quality Assuring the MDT MSK Workforce, and on the 20th of July, we're having a session on community rheumatology. All can be accessed on the Connect Health Change webpage. And thank you to everyone who spoke today on our chair, and thank you for all for listening.